we had gotten to this point yesterday, Tuesday, talking about choice of drug delivery systems, biopharmaceutics, pharmacokinetics, and choosing formulations, choosing type of drug delivery system, choosing routes, etc., etc. I do recall the other day I had mentioned large size capsules. So here's a capsule that I was talking about. This is a veterinary capsule intended for administration to horses and cows, which weigh on the order of 1,000 pounds or more typically. So you wouldn't see these being administered to a patient, and if they were, you can see here, Mrs. Jones, you want to take one of these 3 times a day. I guess you'd have to bring it out in a huge box or something. That it wouldn't fit in a vial. Just in case you were interested. If you take my veterinary pharmacy elective at some point in your career, it has a compounding portion where we actually fill some of these larger capsules. Alright, so types of drug delivery system based upon states of matter, solids, liquids, and gases. Included in solids would be semi-solids, ointments, creams, those types of things that have more definitive, more properties of solids than they do of liquids, although they have a little attributes of each. So solid drug delivery systems can be administered directly as powders. BC powders, which fundamentally is just a form of powdered aspirin with a few excipients in it. Is one such, was invented by a pharmacist many years ago. Tablets. Don't you love it when a patient comes in and says, they're on this medication, they don't remember the name of it. What does it look like? Well, it's a small round white tablet. Well, good. That narrows it down to about 700 different preparations. Why? Because small, round tablets are the easiest and cheapest to make, and if there's no other dyes in there, that also makes them less expensive. So there are a lot. Having identifying marks on them, scores, and even numbers, etc., help to identify these things. Capsules come in a variety of colors and even materials. It used to be that the vast majority of capsules were made out of gelatin, which is from animal byproducts, bones and those types of things that don't go into other meat products. But an increasing number of capsules are now made from plant sources, methylcellulose, and derivatives thereof. Suppositories are solid dosage forms. You will be making these in lab next semester. Inserts into a variety of areas. If there is an opening in the body somewhere, there is a drug delivery system designed to insert into that area. And if you think, well, not there, yeah, there too. Semi-solids, creams, ointments, gels, all the hand sanitizers that are sitting everywhere, that's a gel. It's largely water. The hand sanitizer is about 60% isopropyl alcohol and water, and some methyl cellulose. Liquid drug delivery systems. You look at them and you think, okay, well, a solution, right? Well, then there are suspensions where the drug is not in solution. There are emulsions, and the pictures that pop up are just examples of each. There are elixirs. Elixirs, by definition, are hydroalcoholic solutions, which means they have alcohol in them. But in recent years, you can get alcohol-free elixirs. That's like getting a tobacco-free cigarette. Doesn't make a whole lot of sense. It's not that I like or promote cigarettes in any way, shape, or form. tinctures, syrups. These tend to be sweetened with sugar. There are some sugar-free syrups that don't taste all that good. Usually that's for taste masking. Aromatic waters. There can be rose water is one such. In fact, you'll use that in some of your compounding. If you take a bunch of rose petals and steep them in water for a period of time, you can actually create your own rose water, but it takes a lot of petals. So volatile substances are done in this way. Lotion. Lotions are made kind of like creams, except they're more liquid. And in fact, some lotions will in fact be emulsions. Gas drug delivery systems, aerosols, inhalers are considered gaseous, so we aerosolize something and inhale it into the lungs for its site of action. Insufflations, insufflation devices are actually powder administration that is then aerosolized and taken into the body. What makes these special powders is the powders are very small particle size, somewhere in the range of 2 to 5 microns, so they can penetrate and potentially stay in the lower parts of the lungs. So these devices are kind of unique. You open them up and they have just sort of a little train of individual little packets with powder in them. And what the device does is it perforates each packet, and then the person, by inhaling, will suck the powder out of that. And then inside these devices are little fans or little spinners that cause it to go up into the air and have the powder separate so they can be inhaled. It's one way to administer something that makes it stable, because in these types of inhalers, the drug is in solution and you might have some stability issues with that. It's also easier for a patient to time administering this, as you will find as you go along. You may already know if you puff the inhaler at the wrong time and the patient breathes at the wrong time, they may not get a dose at all. So they have to press it and then inhale as it aerosolizes it in a similar fashion to this, so they can inhale it. Otherwise, it will just impact on the back of their throat.
Would a nebulizer be considered the last one?
Nebulizer would fall into this particular category too. Yeah, same idea. Same idea, except it's in some ways it's a little easier because it's a continuous process. And a person just kind of breathes easy, but it's not as convenient. Can't carry one around with you. I guess you can, but you wouldn't want to. So routes of administration, I'm not going to go over all of these at this juncture. This is a fairly complete list, but it's not totally complete. There's probably something that was left off of this. I extracted this from another source, just to give you an idea of the types of things that are administered in various routes. So oral route, sublingual's under the tongue, parenteral. Most people tend to think of, well, it's just solutions that are injected into the body, and I'm not just talking directly into the veins, but in other places. But there can be suspensions and emulsions. You might want to write that in there. That's another one. Emulsions could also be injected. Suspensions and emulsions are often injected not directly into a vein, and that might be part of its long-acting capabilities as drug slowly goes into solution. Either topical or transdermal, a variety of things are available there. Some old-fashioned things that we probably won't talk about much in class, but you may have heard of, are like a plaster. where you would mix up a drug or an herb or something of that nature. So you may have heard of a mustard plaster or something of that nature. And then apply it topically to a patient. Part of the effect might be from absorption through the skin, but part of the effect might be from the vapors that arise from whatever is mixed in there. In the eye, typically this is local administration, though there are some systemic drugs that can be administered this way. And we can do the equivalent of having a contact lens. Contact lens is a little aqueous sac. That's what it amounts to. And if we infuse that water inside of a contact lens type of material with drug, we could release drug over an extended period of time. Ointments are also used. Into the ear, intranasal local effect, systemic effect also. Directly into the lungs, those tend to be aerosols to get down into the alveoli. With the many sundry branches, when you inhale something into the lungs, at best about 10% of what you inhaled actually makes it all the way down to the alveoli. That's where it needs to go if it's going to be absorbed systemically. So a systemic administration of drug through the lungs is not completely practical as of yet. But it's one of the routes being explored, and in the future may be an administration route for insulin. Rectal administration, solutions, ointments, suppositories, gels, variety of things, believe it or not. Vaginal administration, this is a particular route that avoids first pass effect and is a route that proteins can be readily absorbed from. So it's often used, maybe most often, for local effects in that particular area, but could be used for systemic administration. And urethral administration. There are urethral suppositories. They're not the same shape as rectal suppositories, they're much thinner, but they are inserted into the urethra. Probably see them more often used for females than males, but there are male urethral suppositories. And we will talk about those at the later time. I tend to save the suppositories for the end. Well, that's one of the better ones. And you might say, unfortunately, yes, you're right. That is one of the better. All right, so oral administration. You, of course, know all this. What I want you to get out of this is when something is administered orally, the primary site of absorption of drug from an orally administered drug delivery system is the small intestine. See? Primary site of absorption, small intestine. Not any other place. It's not the stomach, it's not the throat, it's not the mouth, it's not the rectum, it's not the colon, it's the small intestine. Why? Surface area. The surface area of the small intestine, if you looked at the length of the small intestine and considered it a pipe, it doesn't have that large a surface area. But it has folds, it has villi, it has microvilli. So comparatively, the surface area of the stomach is, I don't remember exactly, but it's somewhere around 0.075 square meters or something like that. Relatively small. It's almost just like a smooth sac. The comparative absorbing surface area in the small intestine is 200 square meters. 200 square meters. That's a substantial area. Why is it that way? Because it's designed to be the absorption spot for nutrients. Not for pharmaceuticals, but for nutrients. We take advantage of the fact that it's designed for absorption. Our drug delivery system has to get our drug to that area and in solution so that it can be absorbed. Because that's what that area of the GI tract is designed for. So that is something I do expect you to remember. Small intestine is the primary site of absorption for orally administered drugs. Because then we have to deal with the low pH in the stomach, the higher pH in the GI tract, pH, pKa, Henderson-Hasselbalch, all those types of relationships, ionizations, etc. The most water-soluble form of a drug is its ionic form. So if it's a salt, if it's ionized, that's its most water-soluble form. Its most lipid-soluble form, which makes it its most absorbable form, is its non-ionized form. So we tend to depend upon the stomach as the area for drug to go into solution, which is why a dissolution test has a beaker that's approximately the size of the stomach. That's how it was originally designed. It's also the low pH. A lot of drugs are in their ionized form at that particular pH. So liberation from the dosage form, especially immediate release drugs, tends to happen in the stomach. Advantages. Swallow something, then it gets liberated and absorbed along with everything else, so it's fairly natural to swallow something. Uncomplicated, convenient, relatively safe. Disadvantages is if you swallow a tablet, you don't get immediate relief. There's a little bit of a delay until it's absorbed, until it's liberated and absorbed. There's a chance of irregular absorption or even incomplete absorption. Absolute bioavailability, that factor F. Talk about F. It relates how much gets in to how much we administered. In a perfect world, this is equal to 1. How many of our drugs and drug delivery systems exist in the perfect world? Almost none. There are a few, but almost none. Usually, if we can get somewhere in that range, you're doing good. There are some that are orally administered that are lower than that. There are a few that are higher. And then it's consistency. How I absorb it and how Greg absorbs it and how somebody else over here absorbs it can be different. So mine might be 0.5 and yours might be 0.7 and somebody else over here might be 0.4. That's where individual dosing adjustments are required. So that's why we need to understand these particular processes, because at some point the pharmacist is going to be the one adjusting a patient's dose. Physician diagnoses them, figures out what's wrong, consultation with the pharmacist, puts them on drug therapy, then from there the pharmacist handles the drug therapy. It's not that way yet, it's getting there. You need to be equipped to handle it, and the more you know about what causes this, the better off. Depending upon the pH, that may be a destructive environment for the drug, so we may have to protect it. Some of those modified release preparations, common example. What's one of the side effects when somebody takes an aspirin tablet? It's one of the common sort of local side effects.
Upset stomach?
Causes an upset stomach, partly because it's acetylsalicylic acid. It's an acid putting into an acid environment, and it erodes part of the mucosa in the stomach. So if you take too much aspirin, you can actually create ulcers. So one way to combat that is to make it enteric coated. An enteric coat doesn't dissolve completely in an acid environment. It doesn't dissolve until a basic environment. So it doesn't dissolve in the stomach, it dissolves in the intestine and therefore protects the stomach from its local effect. Interesting thing about that is some research was done a number of years ago and found even when patients were injected with aspirin, they didn't take it orally at all, it still caused stomach upset because enough of the aspirin migrated from the bloodstream into the gastric mucosa to cause stomach upset. So even an enteric-coated aspirin doesn't prevent it. It prevents a large local concentration, but doesn't prevent that kind of side effect. Parenteral routes, a lot of these, but most of these are into other locations than directly into the bloodstream. It's directly into the bloodstream. Here's the difference between the two major routes of administration, extravascular and intravascular. Those that I have starred in with red are directly into the bloodstream, so they have no absorption step. Everything else has an absorption step into the bloodstream. So subcutaneous, intradermal, intramuscular, even intrathecal, into the cerebral spinal fluid. Now that might be your target, so you don't really need an absorption step, but officially to be distributed to the rest of the body, it has to be absorbed into the bloodstream. Intra-articular, into the joints, intraperitoneal, intraocular. Never had one, but they do make injections in, through, or beside the eye. I don't know about you, that would kind of freak me out. Or not, maybe you like that kind of, I don't know. Advantages of parenteral administration as opposed to extravascular administration. Patient can't take it orally, all right? So we'll inject it. They may be unconscious, they may be have an inability to swallow, etc. It does avoid absorption issues, degradation, first pass. Most parenteral routes do. There is a faster onset of action. You can see an almost immediate type of relief. Avoids GI irritation for the most part, except for drugs that still cause it anyway. Can provide some local effect and can be suitable for some long-acting drug delivery systems. You can inject a depot type of medication that might release for weeks to months. So one injection, whereas you might have to take something orally on a more regular basis, even if it were weekly, to have one injection and not have to worry about it for 3 or 4 months. Convenient for the patient. That increases compliance. Drug delivery system choice and construction factors in patient compliance. The most effective drug in the world is not going to work unless the patient takes it. So patient compliance is always a factor in every drug administration. Don't take it, it don't work. You don't put gas in your car, it doesn't keep going. Thinking about putting gas in your car, don't put gas in your car. Disadvantages. That's a little trickier. All of you are certified immunizers, right?
Not yet. Next month.
Not, oh, you haven't done that yet? Oh, okay.
Next month.
When?
This month.
This month sometime? That's right, it's September. It's September! Can we say 1 month down? I know it's only like 2 weeks, but Pretty soon it'll be Halloween, and then Thanksgiving, and then Christmas. Advance advice, don't be a turkey around Thanksgiving. It's not good.
As long as you're not the slowest turkey, you're all right.
Huh?
As long as you're not the slowest turkey.
Oh, that's true. You know, if you're out hiking in the woods and you get chased by a bear, you don't have to outrun the bear. You just have to outrun one person in your party. So make certain when you go hiking you take somebody slow. I may look slow, but I'm not that slow. We digress. Sorry. I never do that. I never digress. Unfortunate thing is once you administer something parenterally, you know, it's there until it releases all its drug. You can't really take it back. In an oral administration, you have some options. You can actually do gastric lavage, you know, the stomach pumping thing, or neutralizing substances or something of that nature. Parenteral products are more costly and difficult to produce. And I throw up EpiPens as an example of that. Yes?
I read an article somewhere that some doctor was trying to combat the price of EpiPens by just prescribing syringes and a vial of epinephrine. How does that, and so that you have to kind of teach the patient then how to use it. So how does those two differ?
Well, certainly convenience and accessibility, but if the patient had to self-administer, have you ever broken an ampule of epinephrine or anything? It's not that hard to teach, but you need to have a clear mind so you don't disrupt the entire process. But you've got the problem of, you know, are they going to break it properly? Or are they going to pull up the correct dose? Because those aren't unit dose in terms of this kind of dose. And the sterility of the situation. I see a lot of issues with that. Now, as you may or may not have heard, the same company that puts these out, they're going to actually market their own generic equivalent at half the price.
You know what's strange stuff that we actually ordered the generic, and when you order the EpiPen, you get 2 pens.
Yes, it comes as a 2-pack.
The generic comes with 1 pen and it's half the price.
Well, Mylan's generic is going to have 2 pens.
You don't have 2 pens.
Yeah, it specifies that. But it will be, in other words, it will be the exact same product, just with a different label on it. Because they own the patent on that product, they can do that. So the other companies that have tried to come out with generics have had trouble with the consistency and the delivery of the device. And a few have tried and had to withdraw them from the market or didn't even have them approved by the FDA. I'm not trying to defend Mylan at all. It's just that it's tough. It's a difficult thing to get into. Do you have a question? Or?
No, just fixing things.
Major parenteral routes, and I'm not going to read all of this to you. We talk about some things: subcutaneous, intradermal, intramuscular. You are limited on how much you can give, and this is one of the things they'll talk about when you do your immunizing training. Is in a subcutaneous injection, you're limited to 1 ml or less. Intradermal, about 1/2 ml or less. Intramuscular, 2 to 5, depending upon the muscle that you're putting it into. That's why some injections that are intramuscular go in your arm, but others like, no, can't be your arm, drop your pants. It's got to be in the gluteus maximus because it's a large muscle. And then you're talking about 4 or 5 mils per injection. If you need to inject more than that, that means multiple injections. So the sites I am into a muscle. Muscle is a pretty big target. Subcutaneous, intradermal, also fairly substantial targets. To hit a vein, those are in particular locations. Sometimes when you're giving an IM injection, you might hit a vein. That's not a good thing. You would pull that out before you push in the material because it's not designed to go directly into the bloodstream. Many of the vaccines that you would be administering are suspensions or emulsions. You don't want to inject that into directly into a blood vessel. So intravenous has an absolute bioavailability of 1. All of the dose that you're administering goes into the bloodstream. So it's complete. In fact, that's the reference standard when calculating absolute bioavailability for an oral drug delivery system, is you would also give a dose IV, measure its area under the curve. That's what you would measure. You measure the area under the curve and compare that to the dose-related area under the curve from an oral administration, and that's where the value of F comes from a ratio of those area under the curves. Advantages, this is where, give a bolus dose of something, tends to be this immediate effect, avoids first pass effect because it's directly in the bloodstream. It doesn't go through the liver immediately. It does eventually go through the liver, but the liver gets what percent of cardiac output? It's about 20-25% of cardiac output is what the liver gets. So part of it eventually goes through the liver. When it's absorbed through the GI tract, 100% of it goes through the liver before it goes systemic. IV infusions are ways where we can give a continuous quantity of drug over a long period of time and maintain a certain drug concentration. Therapeutically, this is what you want to try to achieve. And we can reach this partially with some extravascular drug delivery systems. There are some transdermals, some modified release preparations that release drug in a controlled release fashion, in a zero order fashion, and in that way gives a blood concentration similar to, though not exactly like, an IV, constant rate IV infusion. And IV infusions require injection into the vein. There are some devices that might be attached to a person, an infusion pump doing that. Insulin pump is not exactly the same thing because that's not in a vein, that's actually into the skin. But the concept is similar. Disadvantages. The positive effects occur rapidly, but so do the side effects. IV infusion requires replacement of materials and having someone well trained to do that. Typically, patient would not be able to do this themselves. And you would need to rotate the site at which it's done, because if you inject too often of any type into the same area, you can actually break down the structure of the skin and the blood vessels. And that falls in my category that I classify as that's bad. That joke hasn't got too old yet, has it? Hasn't made that category. Intramuscular bioavailability can approach 1, but usually it's less than that. The muscles are fairly vascular areas, but there is a discernible absorption step. Absorption can be relatively rapid from an aqueous system, but if it's an oily system that's designed more as a long-acting system, then the drug's going to dissolve out a little slower. It's easier to do than an IV injection because the muscle's bigger and you can use larger volumes than a subcutaneous. Disadvantage is it could be painful. The injection itself could be painful. The medication might be in and of itself cause pain in the area because of its pH or other ingredients that are in there. Iron supplements can be given via injection, and they're given using what's called a Z-track injection, where you don't just stick it in and push it, but you actually insert the needle and then turn it to the side and then insert it again and turn it to the side. And at that same time, you're releasing a little bit of liquid so you're not pooling it all in one spot.
That's horrible.
It's not pleasant, but it's worse on the patient if you just stuck the needle in and shot it in all at once because the iron product itself is irritating.
Isn't penicillin the same way? We give that to
The,
people, but
Procaine or the benzathine penicillins are. The just regular penicillin's not.
in the military, they must use whatever's cheapest because it feels like peanut butter.
Yes, those are long-acting agents that are suspensions. They're also conjugates of other ingredients to make them long-acting. And I think the military drug delivery systems are designed to be painful.
I wouldn't doubt it.
That may be a design requirement.
Mm-hmm.
That and $600 hammers.
Of course.
Rate of absorption, varies with, of course, the largest muscle you're using right now by setting on it. Subcutaneous can have relatively high bioavailability, but the absorption tends to be slow because depending upon what part of the skin you inject it into, the upper part of the skin, there aren't any blood vessels there. It's not until you get down into the dermis that you encounter blood vessels, not in the epidermis. So absorption can be relatively slow, partly because what is the purpose of the skin?
Protection. Protection.
Protection. It's to keep things out. It's also to keep things in. So it's designed as a barrier. So for us to use it to administer drug through or from, it's built to resist that. Unlike the small intestine, which is built for absorption, skin is actually built to prevent that. Advantages: easier to inject than IV, which is true of most other parenteral or other parenteral administrations, and self-administration is relatively easy. Again, you have to caution patients to rotate the site because too many injections in the same area, the drug delivery system, and just the trauma of injecting will break down the skin structure in an area to the point that it won't be able to recover. You can permanently damage the skin that way. Disadvantages: can't inject all that great a volume. Rate depends on blood flow and injection volume, and overuse can cause tissue disintegration, as I mentioned. All right. Clickers. So which of the following, and there's only one best choice, is considered a solid drug delivery system? Under normal circumstances. And I'm not going to ask you to something too extreme, not if it's 20 degrees below zero outside. Or the 90 degrees above
No, we
zero.
don't like that at all.
We are currently the second hottest summer in this area. I think there have been 51 days of 90 degrees or more. Record's 55.
You do a lot of your walking outside, right?
Hmm?
You do a lot of your walking outside. Yeah, I tried that.
I know where the shade is.
I had to get a gym membership. I couldn't do it.
I'm tough. All right. Ooh. And the one wrong answer is actually not that bad. Yes, capsule solid attended. An ointment is considered a semi-solid. I recall what might have misled you is the initial slide that had states of matter and had solids and semi-solids listed, there. So, not an unreasonable answer. I wouldn't say it's an entirely incorrect answer. So, pretty much everybody got this right. Great job. Which of the following is a semi-solid? Sometimes I give the stuff away. It's just a matter of words and paying attention. I know nobody in the back row over here heard me. Just for your edification, there's nobody sitting here. Okay. Well, I guess the can is hard. Or there might be something. And capsules, you can put a semi-solid in capsules, but not too bad. So the following is a liquid drug delivery system. Let's see, an ointment and a gel are both considered semi-solids. Capsule, by its definition, is a solid. Inhaler, aerosols. No, syrup. It's one of the examples for liquids that we use. Which one of the following parenteral routes of administration has an absolute bioavailability of 1, and I'll modify this particular question, all of the time? So each of these choices are parenteral routes of administration. IT is intrathecal. It is not to do with information technology. I can't get 100% on it. Now the interesting thing is here, 97 plus 2 plus 2 is 101. I figured it out.
It's a rounding error.
See what bad rounding does for you. So IV. All the rest of them are administered such that they have an absorption step. Now, if I hadn't modified the absolute bioavailability of 1 all of the time, this was a possibility because each of these routes, for certain dosage forms could be 1. So that's not that far out there. Then there's that one. I am of the opinion that there are some people that purposefully choose a wrong answer just for fun, because they don't like to see 100% on it. That's all right. With 3 minutes left in this particular class, what I can do is if